Hello, my name is Dr. Asad and I'm currently working at Epsom and St Heliers Hospital. Today we're presenting our analysis on deep vein thrombosis or DVT referral pathway to our same-day emergency care unit at St Helier. This project arose from concerns about long waiting times for ultrasound Doppler scans and the potential inefficiencies in our system. At St Helier, patients presenting to accident emergency with lower limb pain, swelling, and elevated D-dimer are often referred to STEC for Doppler sound scans. While this pathway is well-intentioned, in practice it has led to a very high number of referrals to a limited ultrasound service. In fact, patients can sometimes wait, as we've seen, up to 10 days for their scans, creating delays in diagnosis and unnecessary anxiety. This raises important questions. Are we over-referring? And could our use of D-dimer as a triage tool be contributing to inefficiencies? So if you look at the aim section of the poster, the aim of our project was to review the current referral pathway, to audit the outcomes of DVT referrals from both A&E and GP services, and to assess whether the reliance on D-dimer is an effective triage tool. In our method sections, you can also see that we carried out a retrospective review of 74 patients referred for our suspected DVT to our medical assessment unit. For each patient, as you can see, we collected demographic data such as age, gender, presenting symptoms, D-dimer results, and ultrasound Doppler findings. We then performed statistical analysis, including the Kolmogorov-Smirnov test, to evaluate the relationship between D-dimer levels and the likelihood of a positive Doppler result. You can see on the results page the average age of patients was around 64, and there were slightly more women than men in the group. You can see on the demographics table or graph that out of 74 Doppler scans which were performed, only 7 confirmed DVT. That's just 1 in 10 referrals, 10%. If you look at the overall results chart, this means that the majority of patients underwent unnecessary scans, multiple hospital visits, and in some cases unnecessary initiation of anticoagulation, while still facing delays in the definitive diagnosis. When we look more closely at the data, patients who did have a confirmed DVT tended to have much higher D-dimer levels, typically above 2000. You can see on the graph showing the D-dimer distribution. The difference was statistically significant, with a p-value of 0.0005. However, D-dimer on its own was still not a reliable triage tool because false positives were very common. Many patients with high D-dimers did not have DVT on ultrasound. This reinforces what we already know clinically, that D-dimer lacks specificity, especially in older patients or those with comorbidities. In conclusion, our audit shows that the current referral process is inefficient and places unnecessary strain on both patients and services. The low yield of positive scans highlights the need to rethink our pathway. We suggest moving away from using D-dimer as a main triage tool and instead placing greater emphasis on clinical evaluation and validated scoring systems such as Wells criteria. If you look at the recommendations site, by refining the pathway, we could reduce unnecessary scans, shorten wait times, and improve patient care while making better use of limited NHS resources. Thank you very much for listening. This analysis has already generated useful discussions locally about redesigning our DVT pathway, and we hope it can contribute to wider conversations about how to balance diagnostic accuracy with efficient resource use. I'll be very happy to take any questions you might have. Thank you.